Welcome, everyone. Thank you for joining us today for MVC's Post Discharge Follow-up Workgroup presentation. My name is Rachel. I am one of the Site Engagement Coordinators with MVC, and I'm happy to be here facilitating for you today. For our agenda, we're going to be going over some of our normal housekeeping and P4P credit reminders. Then we will have a presentation from MyMichigan on their continuing care clinic. Following the presentation, we'll have a short question answer time, and then I will close out the work group with some MVC upcoming events and updates. Just some of our general housekeeping reminders. Just be aware that the work group is being recorded. All of the slides and the recording will be shared with attendees following the work group via email. The recording is also available on YouTube. If you find us on YouTube, you can watch that there. Please remember to mute your microphone during the presentation. This just helps reduce any background noise and confusion. And then if you have questions throughout the presentation, please feel free to put them in the chat, and we will go through those at the end during the question discussion time. Just a reminder for our P4P participating sites, we ask that you are an active participant during the work group today. So that means asking questions during discussion time would be great. And then also a reminder that we will share a link for the post work group survey at the end of the work group. This will also be in the email that we send out. That is required to receive your engagement points for the work group today. So please make sure to fill that out. As a reminder, just one survey per site per person who attends the work group. And then if you do not do P4P, we still would love you to fill out the survey. It helps us kind of gauge feedback on how the work group went, what you thought was interesting, or what you would like to see in the future. So today's presenters are Stephen Frazier, who is the Director of Quality and Patient Safety in Post-Acute Care at MyMichigan Health System, and Dr. John Hagan, who is the Medical Director at the Care Coordinating Center of MyMichigan Health System. Stephen serves as the Director at MyMichigan, where he leads system-wide initiatives to improve care quality, strengthen patient safety, and drive better clinical outcomes. Since joining the quality team in 2021, he has focused on advancing a culture of quality through staff education, EHR optimization, and programs that promote continuous improvement. Previously, Stephen led ambulatory clinical services, overseeing care management, patient navigation, and behavioral health programs that support patients with complex medical and behavioral health needs. He began his healthcare career as a psychiatric and substance use treatment nurse. Stephen holds degrees from Lansing Community College, Michigan State University, and Saginaw Valley State University. John Hagan is a board-certified family medicine physician practicing in Midland, Michigan. He is also the medical director of MyMichigan Health's Continuing Care Clinic. He has been in this role since August of 2024. Lost my notes. He completed his family medicine residency at Ascension Providence Hospital in Southfield, Michigan, and he graduated from Michigan State University's College of Osteopathic Medicine. In his spare time, he enjoys reading, writing, and spending time with his family. And with that, I'll be handing the presentation over to Dr. Hagan.
Right. Can you guys hear me okay?
Yes.
Okay. So like Rachel said, my name's John Hagan, and I'm joined by Steve Frazier. We are here on behalf of MyMichigan Health's Continuing Care Clinic. Steve spoke to this group nearly 2.5 years ago when our project was in its infancy, and a lot has changed since then. So today we're going to tell you about the clinic, some of the challenges that presented themselves, and the solutions that we implemented. Next slide. MyMichigan Health has over 10 medical centers across 26 counties in Michigan. The hospital system has over 1,100 hospital beds and employs over 13,000 people, including 2,400 physicians and APPs across 80 plus specialties. And in fiscal year 2025, MyMichigan Health provided $243 million in community benefits and other uncompensated care. We strive to provide quality health care to every person in the communities we serve, but we face challenges just like everyone else. We target key performance indicators and try to develop exceptional solutions to the problems that arise. The continuing care clinic is one attempt at such a solution. Next slide. So we opened in August of 2023. We had 2 locations, one in Midland with 2 providers and one in Alma with a single provider. We staff the locations with personnel that can help us achieve our mission. If you go to the next slide, Rachel, I'll tell you a little bit more. We had 2 major goals at the outset: reducing hospital admissions, readmissions in patients with a primary diagnosis of pneumonia, and improving timely access to care. Because hospital readmissions place a significant burden on our patients, their families, and the health systems that serve them, this is what we chose to focus on. While many variables contribute to whether patients get readmitted, research indicates that insufficient follow-up after discharge can play an outsized role. Ideally, follow-up after hospitalization should take place by day 7 with the patient's primary care provider. We know this doesn't always happen, and there's a lot of reasons for it. For one, there's a primary care provider shortage, and in general, more rural geographies experience this shortage more acutely. This results in long wait times to get appointments for established patients, even longer wait times for new patients to establish with a primary care provider, and large numbers of our populations living without primary care. So if you don't have a primary care provider, you don't have anybody to follow up with when you get out of the hospital. And even if you arrange for a new provider while you're admitted, wait times for new patient appointments often stretch out for months. And even if you have a primary care provider, they may not have space reserved in their schedule for timely hospital follow-up. And it might be weeks to months before they can get you in. These realities lead to significant gaps in care, and the continuing care clinic is designed specifically to fill these gaps. Next slide. So hospital follow-up was the area where we felt the greatest impact could be made. We wanted our patients to be able to heal at home with confidence. We know patients are in a vulnerable state after hospital discharge, and timely follow-up can alleviate a lot of those vulnerabilities. Hospital readmissions often occur between 10 and 14 days after discharge, and by seeing our patients before that, we improve their chances of staying out of the hospital. The discharge patient faces many challenges that are often foreign to them. They may have new medications, they may need to change their lifestyle, they might require follow-up testing or consultation with specialists, and they often do not remember all of those things. The follow-up appointment can provide some clarity. These aspects of the post-hospitalization period make for a very complex and time-consuming encounter, so we staff specifically to solve those problems. Go ahead and next slide. We start by providing the right care at the right time, all in one place, and we aim for a seamless transition from hospital to home. Our follow-up visits allow an opportunity for ongoing assessment, continued monitoring, and confrontation of any emerging issues. The provider ensures patients are taking medications as prescribed when they were discharged from the hospital. They can make any necessary changes, and patients in our clinic have access to an on-site pharmacist who can walk them through any questions they might have and follow them moving forward to tailor treatments to that individual's needs. We educate. So after each visit, our nurse care manager offers patient education through clear instructions and personalized guidance on self-care, lifestyle changes, and symptom management. This empowers the patient to potentially identify any complications or signs of relapse promptly. Our nurse care manager, in conjunction with the patient and provider, is also prepared to address goals of care discussions through advanced care planning. We have patient care navigators and community health specialists that help coordinate care and identify any social determinant of health barriers and subsequently connect patients with established community resources. This includes transportation assistance and food banks. Another service we offer is on-site behavioral health intervention through our behavioral health therapist. She can often meet with patients on the day of their appointment with the provider and continue to follow them moving forward. Our staff also works to connect patients to their forever home by reaching out to schedule new patient visits with a MyMichigan primary care provider. The work that we did when we started opening the clinic provided us with a guide to meet the challenges that arose in time. Next slide, Rachel. So it quickly became clear to us that hospital discharges alone did not provide sufficient volume to sustain our clinic. We realized that for every hospitalized patient we were seeing who was not established with a primary care provider, there were many more in our community who had not been hospitalized. So we opened up our availability beyond hospital discharges to all patients historically underserved within our community. They came to us from emergency rooms, urgent cares, and inpatient psychiatry. Then we realized that because of provider shortages in our geographies, we struggled to transition our patients to their new forever home in a timely manner. This necessitated that we provide primary care for our patients for up to 6 months before they got into their forever home. And this new approach, it was frustrating for the providers that we had at the beginning. They were hospitalists by training and experience, and they had applied for the job, emphasizing hospitalization follow-up. Eventually, those providers moved to opportunities that better suited their interests, and we had to find new providers. Finding the right provider was a big challenge. Our mandate is fairly unique and required the right type of person to help our patients meet the challenges they face. So we required somebody who had adequate experience to care for complicated patients. They would have to navigate many comorbid conditions simultaneously. They wouldn't know these patients before that first visit. They'd have to accommodate poor health literacy and unreliable transportation, and they needed to be comfortable managing psychiatric comorbidities and controlled substance dependence. Next slide. So the CCC became it became and is now a comprehensive transitions of care clinic. And transitions of care are everywhere in medicine. The hospital transition was our initial emphasis, and it remains so, but now we welcome patients who are new to the area and transitioning from their old provider to a new one. We take care of all their needs in the meantime. A patient may be transitioning from not having had care for decades to becoming a member of the MyMichigan Health System. We take care of them, and we kind of introduce them to healthcare culture. A patient may have been in ER, urgent care, or psychiatric care, and if they don't have a place to go when they leave those places, we take care of them. And we've done this well with many successes over the past 2.5 years. Next slide. So while addressing the barriers that came up that arose within our clinic, we've been able to maintain a 7% readmission rate for hospital follow-ups. That's better than half that of our health system as a whole. Our lead times for hospital follow-up remain at 8 days, 7 days for new patients, and 6 days for ER follow-ups. We've dramatically brought revenues closer to expenses over time, and we steadily increased patient visits over fiscal year 2025. Workflow improvements allowed for patients to move between resources within our clinic in ways that freed up our provider to offer more visits. Initially, visits were scheduled at a rate of 1 per hour, and we've moved that down to every 40 minutes for the provider. We initiated a CCC red carpet program in which our nurse care manager visits the hospital to establish a relationship with prospective patients before that patient is discharged. He explains at that time what our clinic has to offer to prospective patients. We've brought a substantial number of unique patient lives under the MyMichigan Health umbrella. We've maintained remote telemedicine services with our more rural geographies, including Sault Ste. Marie, West Branch, and Alpena. And last year, MyMichigan Health was presented with the Michigan Health and Hospital Association Ludwig Community Benefit Award for the continuing care clinic's efforts in aiding in communities in extraordinary ways. Next slide. I wanted to take a little time to review the process that we've settled into over the last couple of years. It's fairly straightforward, but the logistics are complicated. As an example, we'll look closer at a hospitalized patient. The initial step is identifying patients that we can help. Someone at the hospital must recognize that a specific patient does not have a primary care provider. From there, this knowledge has to be carried forward with the patient through to discharge. As the patient is being prepared for discharge, someone needs to act on that knowledge by scheduling the patient in our clinic or facilitating that scheduling by contacting us. Once the patient's scheduled, getting them to that appointment is another matter entirely. We provide multiple points of contact prior to the appointment. Once they make it to the appointment, we provide a one-stop shop for all their healthcare needs. The provider performs a visit, they reconcile medications, review the follow-up plan, educate, and reinforce or modify the plan moving forward. Then patients meet with the nurse care manager for further education. If behavioral health needs are identified, the therapist can schedule them for follow-up or even perform a face-to-face visit that day. If the patient has complex medication management needs, the in-house pharmacist can provide additional guidance and education. When SDOH needs are identified, we utilize our connections with the social work department to address those needs. All or some of these things are included in every CCC visit. During the patient's visit, our on-site supervisor works behind the scenes on getting a new patient appointment with a primary care provider near the patient's home. Between the visit and establishing with their new PCP, the CCC remains the patient's temporary medical home for all of their healthcare needs. Next slide. Just to understand the full impact of our clinic, we don't want to forget the most important piece, and that's the patient's perspective. So I just wanted to share with you a few of the reviews provided to us through our anonymous patient review system. So the first one, this place is essential to the community, and I am so grateful to be a temporary patient here. We are a safety net for our underserved community members. The second one, I felt like I had a much better understanding overall of my diagnosis and different things that have recently happened. So we educate and empower the patients. I was running a little late and they were still friendly and got me seen right away. If a patient shows up late to our clinic, we don't ask why. We work them into the schedule and provide the full experience to them while they're in the clinic that day. Last one, I would tell my family and friends I had the best experience ever. These people are passionate about what they do, showing true care and compassion. Every member of our team works tirelessly for our patients to feel this way when they visit our clinic. Next slide. So I hope what I covered here today gives you guys a good idea of what the continuing care clinic has brought to MyMichigan and the patients that we serve. Thank you for your time. If you have any questions, Steve and I would be happy to answer them right now.
All right, thanks, Dr. Hagan. I'm going to move this up. Okay. All right, so we do have one question in the chat from Marina. It says, have you had any issues with patients not transitioning and wanting to stay at the CCC?
Yes. Yes, we have. So it happens frequently because of a lot of our patients don't have primary care providers, or they've had primary care providers in the past and maybe not had a good experience. We often get the question, can you just be my doctor? So when I was seeing, I saw patients in the CCC, I still do, But for 4 months, I was seeing 8 to 10 patients a day. And I got that question almost every day. Um, so that's a challenge. My panel's full in my family medicine practice, so I'm not able to take a lot of patients from the CCC. So we do have to transition them. A lot of people we see do travel, so we try to soften the blow by telling them we're going to find somebody for you that's a lot closer to your home. Um, and then you have people who, let's face it, the population. One of the reasons they might not have a PCP is that they don't emphasize the importance of following up, so they have trouble making it to appointments, and sometimes they don't follow up with the appointment that we've established for them, and they want to come back and see us. We usually will see them once and then try to get them a new appointment and explain to them that the importance of following up with that new provider, and that usually goes pretty well.
Awesome. Thank you. Looks like Annette has her hand raised. Annette?
Hello, Dr. Hagan. I'm
Hi.
actually with MyMichigan. I'm up in the Sioux, and I had our quality initiative up here. I'm a respiratory manager as well as sleep center manager, cardiopulmonary rehab, all the things. So I absolutely love that MyMichigan has this program. And as you said, it's new up here in the Sioux. But I heard this presentation back kind of more at the infancy of the CCC. And I'm wondering if now that we're at it for several years, do we have any data on the back end about an impact to readmissions or a decrease in readmissions for these high risk for readmission, kind of unattached, sometimes non-compliant, sometimes very complex comorbid patients? Do we have any data yet that's supporting, like on the back end, that it's kind of like paying for itself in this way with better outcomes and so forth?
I'm going to let Steve talk.
Okay.
So no, yeah,
That's okay with you, Steve.
of course, yeah. No,
Okay.
so thank you Matt, for the question, and that is definitely one of the metrics that we've been tracking since really the inception of the continuing care clinic. We've been really tracking closely what the readmission rate is overall for the patients that we serve, and when we took a look at the population, we definitely recognized that this patient population is at a much higher risk than the average population within our community. So when we look at their performance from a readmission rate standpoint, yeah, we are about half of what a comparable clinic is in our geography from a readmission rate standpoint. So we're at 7%, 7.0% readmission rate, all cause across all the patients that we've served with transitions of care. And around 14%, 13-14% is what we see in the community. So it's been very rewarding to see that impact to our patients.
Does that equate, have you been able to sell to like a, executive leadership, I don't know, the payback, so to speak, right? Because
yeah,
if you're another hospital that doesn't if you're a health system that doesn't yet have this, and so, participating in this group and want to be able to take that back, are there numbers that have like supported that you're paying for yourself in that?
Yeah. No, yeah, great point. I say we're winning over our financial friends. I think sometimes they kind of consider readmission rate dollars or avoidable dollars, soft dollars, I guess you can say, from a finance standpoint.
Yeah.
But I think it's very evident that, yeah, we are impacting, some of the major chronic conditions that we typically will see penalties in. So it is getting better, but I would say there's always a little bit of hesitancy when it's not tangible for them, I guess you can say.
It's hard on these things, like our outpatient cardiac and pulmonary rehab's the same way. The money isn't on the front end, it's on the back end, and it's on the quality outcome for the patient. They're like all of those things, but it's difficult in like you said, in a tangible way, to show that it's worth the investment, from the bean counter. So I was just wondering how we're doing on that. Thank you for your time.
Thank
Thanks,
you.
Annette. All right, we have a question from Michelle. She is saying, she says, this work is awesome. Are there any plans to expand this program to patients with a primary care provider, but who they don't have access for follow-up care? I'm not sure if that is clear.
I don't know, Dr. Hagan, if you want to speak to that, or I can. It's up to you.
Go ahead.
So yeah, I think that is definitely one of the areas that we're looking at. I think at times, if we have sensed some hesitancy with patients when we say, well, we're willing to get you in and see you, but your provider can't. And sometimes the patients aren't willing to go to a brand new or different provider post-acute. They want to see their PCP. So we've tried. We're working down that path. I think that we've made some strides. It's still a work in progress. I think that it really does require a hardwired workflow. We have been pulling in our care managers into the process. So one of the first, I guess you could say, cycles of the PDCA has been utilizing our care management team. So whenever they make a TCM follow-up phone call to our patients and they recognize that, hey, this patient is not going to be able to be seen within that 14-day window, then they are trying to help navigate that patient into our direction to help schedule them and see them. But it's something that we're still working on. I think that there's some patient hesitancy. I also think there's maybe some practice hesitancy as well because providers want to see their patients, and so I think we're still working on building that trust, but also breaking down some of those barriers, that trying to really make sure that we emphasize that it's in their best, to the patients, from the patient standpoint, emphasize that it's in their best interest to be seen, to avoid the likelihood of being readmitted. So, but yeah, that is definitely on our radar, but it's still a work in progress.
Sure. Thanks,
And
Stephen.
Dr. Hayden, do you want to add anything? Sorry, Rachel.
Oh, you're good. You're good.
Uh, we are interested in expanding. The timeline for that, though, is complicated. Certain things that we've identified are that it helps to have a fairly large number of hospital discharges in close proximity to where we're going to stand up the clinic. And then we can spread out the clinics, what the clinic provides through telehealth services. But having that core volume that comes from a larger metropolitan area or the larger population does help. That, yeah.
Thank you, Dr. Hagan. Natalie has a question. Can you explain the CCC Red Carpet program a bit more?
Sure. So our nurse care manager is Todd, and we initially started this because of no-show rates, and hope to reduce no-show rates. It was one thing to have somebody at the end of your hospital stay say, we made you an appointment for these guys over in Midland or down the street, and you're going to go see them on this day. Todd goes out to the Midland Hospital and he looks at the census and identifies patients who are hospitalized without PCPs, who don't have any follow-up, and he goes to their patient room. He introduces himself. He introduces everything that we do at the CCC, and encourages them to follow up with us, invites them to follow up with us, and asks if they want to make a patient appointment. And then if they say yes, we get them scheduled right then. And they still have multiple points of contact before they actually their appointment with us. But that's the premise behind the red carpet program, is that we have representatives from our clinic who go to the hospital to identify patients that we can help.
Okay.
And just to complement what Dr. shared so far, I think we definitely saw there were some inconsistencies with how the process or how the handoff process was as well. We had a lot of patients that need to be discharged in a short period of time. And some of our part of the cycle, part of the PDCA that we were rolling out was, making sure we have that dedicated time to really explain the purpose, kind of like what Dr. Hagan was sharing. So we have seen that has improved the likelihood that the patient will show up. There's also, I'm not sure if you mentioned this, Dr. Hagan, or not, but we also do a pretty extensive reminder program for these patients as well. sometimes calling 2, 3, 4 times, sometimes calling right before the appointment, verifying and validating that they have transportation, that we can try to connect them with something if there is a barrier to getting into the clinic. We found that the combination of that pretty extensive reminder process plus also explaining the why and getting engagement early on and putting a face to a name, I think that's really what's helped us with getting those patients into our doors.
Awesome. Thank you. Brandy says, great job. Who sets the original appointment with the clinic?
It differs. So is it the throughput coordinator, Steve, at the hospital can do it. Todd can do it while he is visiting in the hospital, or if they cannot get an appointment or find a time for a slot for appropriate follow-up, they can call our clinic and our nurse supervisor, Allie, will find space for them. If it's really important that they follow up within a few days, we will find space for them.
Okay, great. I do have a question from Karen that you kind of answered already a little bit with the transportation part, but she asks, many of our folks do not have help at home. What community resources are available for your patients?
I could share. So it kind of depends on the community. We try to partner with as many community organizations as possible. We try to work with United Way partners. We also have a foundation within our health system that we can utilize. One of the things that, for example, we have a food pantry inside the clinic. So we use dollars from the foundation, which is basically from the hospital, from donations to make sure that that's stocked. So it depends on the community, but also it's really leveraging those relationships with outside organizations to help support us. Anyone and everyone that's available, we try to connect with for these patients.
Right. Thank you. Now that the program has kind of been established for a few years, Alicia has asked, do your physician colleagues perceive the clinic in, a different light or in a different way than they did when it was initially established?
I think so. It's mostly anecdotal and just interpersonal relationships with the providers that are in my office in the family medicine clinic. It's nice that we kind of tee things up for them. They're not meeting a patient for the first time, and that patient is very unstable. So that's appreciated. I know that our hospitalist group appreciates the work that we do because it reduces hospital readmissions, but also that they are confident and have become more confident over the last couple of years that when they discharge somebody and they're going to see us, they're in capable hands.
Yeah, and I think that just knowing, I think there's a lot of trust there as well. I think that from an emergency department standpoint, there's a lot of patients that are discharged home and the providers are unsure if they're going to be able to get in with a provider, and sometimes they're on the fence, like either we're going to admit this patient because we don't really have good follow-up, or we can send them to community or the continuing care clinic. So I think we've been able to kind of fill a gap there as well. Urgent care providers also love the knowing that they're going to have close follow-up, and some of those patients are kind of on the edge of, should we send them to the ED, or can we get them in within the next day or two over at the CCC to be seen. So I think it's just been a lot of positivity. I know the hospitals love us as well because it helps with discharge planning and that length of stay. But I think it's all about those relationships that have been built over the last couple of years as a trustworthy resource.
Great, thank you. We have a question from, looks like Dr. Watson. Dr. Hagan, curious if primary care practices that have frequent admissions to the hospital reach out to their patients while they're admitted to get them a follow-up appointment in their clinics, and do they stress the importance of that follow-up visit?
Um, I guess, do you mean like for myself as if I had a high risk patient, is my office reaching out to make sure that we get adequate follow up with them? Um, for I can only speak from my perspective, which is um, I will double book and so finding space in the schedule for a quick hospital turnaround is not a problem. But there is a lot of variability between practices, well, within practices and then across the hospital system. So I can't, uh, we do have people who are falling out of that 14-day window for hospital follow-ups. And we the continuing care clinic has tried to emphasize that we will see them for you for a one-time visit if you can't get them in. We are we're working on that, but it's an ongoing problem getting people in after they've been hospitalized.
Right. It looks like Jennifer has a question. Have you experienced any barriers related to payers or billing for the services you're providing?
That's probably a Steve question. I take all comers. I so yeah, yes is the short answer, but Steve can provide some
Yeah.
more meat there.
I would say that, we do have a payer that, with the services that we provide, if we're not listed as a primary care provider that's been assigned to the patient, it does create challenges. But I would say for the most part, we have not ran into denials outside of those kind of situations. I think BCN, I would say, is probably one that comes to mind where they automatically assign a primary care provider to the patient. But other than the normal, I would say that other clinics, I don't think we experienced any type of denials, more so than other clinics experience.
Thank you. Looks like Annette has a question.
Steve, are we able to see like VA patients and tribe patients? Like if they don't have vouchers or those prior auths, that situation, we don't have billing problems with them?
Well, so that's a good point. So there are some payers that require approval. There's some that for, like, I think for the tribes, for example, we will see those patients. We will offer, if they can't afford a copay or out of pocket on it, we will offer assistance there as well. So we'll welcome all that are interested in our services, but we do want to make sure up front if there is a payer specific issue or a potential gap in coverage, that they're well aware of that and they're accepting the fact that they could receive a bill. But know that if you do get a bill and you can't afford it, to let us know, and we'll work with you with our patient financial services to see if we can get that taken care of. The foundation for the funding that I was referring to earlier, on many occasions, we've had to use those dollars to support the patients that can't afford it. It may not be eligible for the write-off as far as like the write-off policy that we have for the hospital. So I would say that we're pretty successful in that area.
All right. Thank you very much. Karen has a question. Your hard work has probably decreased ED visits. Is that correct?
I don't know that we have specific data on decreasing ED visits, but again, it's anecdotal. I see the ED providers in the community, and it does seem like they see that it offloads some work for them.
All right.
And we've had patients in the past that they will spend 5 out of 7 days a week in the ED, and the ED has us. They can contact us and say, we have got to work together to keep this patient out of the ED. And we've had those patients and been successful at limiting those ED visits.
Okay, awesome. And then Kelly asks, sorry if I missed this, but is this any hospital is this for any hospital discharge or for specific populations, surgical?
Specifically, we've historically seen patients that don't have a primary care physician. If it is a surgical follow-up, we will see them. Steve, I don't know if you can speak to that more about.
Yeah, I would say we typically try to steer them back to the provider that did the procedure, I guess, as far as a post-op follow-up. But to Dr. Hagan's point, often those providers are not willing to manage the patient, and especially if they don't have a primary care provider, they kind of end back in that vicious cycle of not having support. So, yeah, we're open to anyone and everyone that needs that level of support post discharge or post procedure as well.
All right, wonderful. It looks like our questions are kind of calming down, so I think we'll go ahead and move on unless anybody has one last question they want to ask. We'll check for hands raised. Looks like I think we're good. Okay. All right. Well, thank you so much, Stephen and John. It was great having you guys as presenters. You provided a lot of great information. I'm going to move us on forward to our MVC updates. So some of our upcoming events, we have next our MVC preoperative testing work group on Tuesday, April 7th. This will be a presentation by Bronson Health System on their recent work with pre-op testing. And for our P4P program participants, you can expect the final P4P scorecards to be sent out in April. And then our upcoming MVC Spring Collaborative Wide Meeting registration will be opening next week. I'm sorry, the following week. So not next week, but the next week after that. Sorry, I meant to put the date in there. And as always, we are looking for presenters for any future work groups for 2026. And then we will have our fall collaborative wide meeting in October. So definitely send us some presentation ideas you have, whether it's for breakout sessions, work groups, poster presentations, all of the above. We're interested to see what you got. Other than that, thank you so much, everyone, for joining us today. Emily is going to share the post work group survey link in the chat, and then we will be sending an email with all of the information from today's work group. Thanks for attending.